rise for the pledge.
Pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Welcome to the August 14, 2024 regular meeting of the Washington Township Healthcare District Board of Directors. Public notice for this meeting has been posted appropriately on our website. Tonight's meeting is in person and is also accessible by Zoom. I ask that you please mute your system until such time as you need to speak. We are recording tonight's regular session of the board meeting. It will be posted on our website for future viewing. Shirley, roll please.
Director Eapen?
Present.
Director Wallace? Director Nicholson?
Present.
Director Yee?
Present.
And Director Stewart?
Present.
Thank you.
Moving on to oral communications, members of the public are invited to speak during oral communications. When prompted, please state your name for the record and then proceed with your statement not to exceed 3 minutes on issues or concerns not on the agenda and within the subject matter of the jurisdiction of the board. Are there any members of the public who would like to speak at this meeting? Okay, no? Shirley, any written communications?
There are no written communications.
All right, so we will move on to the consent calendar. The consent calendar consists of those agenda items that the board will approve with one motion unless either a member of the board or a member of the public requests you to remove the agenda item from the consent calendar. If any items are removed from the consent calendar, the board will take action on the removed agenda item later in the meeting under the action item heading of the agenda. Does anyone on the board want to remove an agenda item from the consent calendar? No? Does any member of the public want to remove an agenda item from the consent calendar? No? All right, so may I have a motion to approve the consent calendars items A through C? Director Nicholson.
Yes, Mr. President, I move that the Board of Directors approve the consent calendar items A through C.
Director Eapen?
Aye.
Director Wallace? Director Nicholson?
Aye.
Director Yee?
Aye.
And Director Stewart?
Aye.
Thank you.
So now we are going to make some switch here. Take an action item and out of order and do it right now. It is actually a commendation of Dr. Ben Starr. So,
Okay. Mr. President, I move that the Board approve the commendation for Dr. Ben Saw, Board President, Board of Directors of Washington Township Hospital Development Corporation, DEVCO.
all right, so there's a recognition. I'm just going to read the text. I'm honored to do this, Dr. Ben Saw, for all your services. Thank you. In recognition of dedication to the Washington Hospital Healthcare System and to service on the Washington Township Hospital Development Board Corporation, DEVCO, Board of Directors. Washington Hospital Healthcare System and the Washington Township Healthcare District formally recognize and acknowledge Ben Saw, MD, for his 48 years of leadership and service to the healthcare system. Dr. Saw joined the Washington Hospital medical staff in 1973 until 2007, providing otolaryngology care to our community, and held many leadership roles, including as the Chief of Staff in 1983. He served on the Healthcare District Board of Directors from 1988 to 1992, and from 1993 to 2002, including Board President in 1991, 1995, and 2000. He then served on the DEVCO Board of Directors from 2010 to present, and as Chair and President of the Board for 12 of those years. During his dedicated service as a DEVCO Board member, Dr. Saw provided instrumental leadership and oversight to important programs to serve the health needs of our community. These programs include Washington Radiation Oncology Center, Washington Outpatient Surgery Center, Washington Outpatient Rehabilitation Center, Washington Medical Building, and the more recent Peninsular Surgery Center. During his district board leadership tenure, he also helped establish access to many important programs, including for recruitment and retention. It handles the on-site daycare at Washington West. Through his leadership on the DEFCO board and his healthcare system leadership roles, Dr. Shah helped improve access to high-quality, advanced healthcare for our community that will have a lasting impact for decades. With the highest regards and accolades, we proudly present the certificate of commendation in honor of Dr. Ben Shah.
I'll happily second
Yeah, let's second it. Do roll call?
Sure.
Oh, yes. Director Eapen? Director Wallace? Director Nicholson?
Aye.
Director Yee?
Aye.
And Director Stewart?
Aye.
Thank you.
Yes.
Proud to do that.
And Ben, I'm sure Mike would
Yeah,
join in with us if he
yes,
were here.
absolutely,
All right.
absolutely.
You got this background? Backdrop?
We'll do that, and then we'll get the full board.
Yeah. Right.
I know. All right, why don't we get the rest of the board members up? Yes.
You got the next one.
Please. Next time.
Ready? 1, 2, 3. Good. Thank you so much.
Then that's like.
Yeah.
Pleasure. Also, to be part of happy.
We're grateful for all that you've done for so many years, in so many roles. And you truly exemplify the culture and values of this institution, which is service from the community to the community. So as a community member, truly exemplify that. So thank you so much for your hard work.
You put that word.
He always,
Yeah.
with great respect.
Yes, and Dr. Saw, I just want to say, I appreciate the many, many years of working with you. Your leadership has been instrumental to our success, and the vision and the expertise that you have brought to the Development Corporation Board has been invaluable, and your partnership with me, I will truly treasure for years to come. So thank you very much for all that you've done.
I wish you all luck.
Yeah.
Yeah,
So,
thank you.
Thank you.
Thank you.
Let's give,
Thank you, Russ, for being
yes.
here. Thank you.
yes.
You don't get to leave without taking a treat.
We should give him a,
Yeah.
For you.
Yeah.
You want for you and
To-go tray.
Yeah.
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 Hey.
And Marla? Did he slip out already?
Wrestling?
He was ready to get out of here.
Hard to keep up with that guy.
I think he might nominate him.
Oh. Yeah.
Guys, let's give him one more, let's give him all two.
For Eva.
Yeah.
We'll do a couple of each later. There we go.
Oh,
Jeannie, yeah.
I jumped on it.
thank you.
It was gonna be competition.
Night, Dr. Saul. Thank you.
Good night, you.
Help out.
Oh, the door's wide open. Yeah.
So, moving on, we'll go to the reports.
Yes, now,
Presentation.
we have a presentation. I'd like to introduce Joanne Pedetta. She's with American Heart Association. And Joanne has been with the American Heart Association for 20 years with over 10 years of quality improvement experience. She is currently a program consultant for healthcare on the Heart Association's Quality Outcomes Research and Analytics team. She will be presenting 2 important awards this evening to our healthcare system. These awards demonstrate the true collaboration and coordination among departments, staff, and physicians. Their efforts have saved lives, reduced suffering, and have always focused on the patient-first ethic. And again, really want to thank all of the staff, the physicians, everybody that's been part of both the stroke and the STEMI programs. They have truly made a difference to this community and to our patients, and really are the champions here in terms of it. So thank you, and welcome, Joanne, to this board meeting.
Thank you. Thank you for having me. I'm going to go ahead and share my screen. Just confirm if you see it.
Yes, yes, we can see it.
Well, good evening, everyone. My name is Joanne Pineda, and I'm a healthcare quality program consultant with the American Heart Association. On behalf of the American Heart Association, it is a privilege to be here today to honor your achievements and to celebrate with all of you. In June of this year, the American Heart Association turned 100 years old. From a humble beginning in 1924, founded in Chicago by 6 neurologists, the American Heart Association has emerged as the largest and oldest voluntary organization working to improve the quality of heart and stroke care across the globe. For a century, the Heart Association has fostered continuous quality improvement through hospital and healthcare programs to ensure everyone gets the best possible care. During its 2nd century of bold action, the American Heart Association is committed to advancing health and hope for everyone, everywhere, with our mission to be a relentless force for a world of longer, healthier lives. At the American Heart Association, one of our main goals is to translate science into practice. The process begins with a question, guidelines and recommendations are issued, education, data collection, implementation, and new research. Each of these parts work together as a cycle that continuously grows to influence the whole industry. And that's where Get With The Guidelines comes in. Get With The Guidelines was introduced centering on 5 core programs: atrial fibrillation, coronary artery disease, heart failure, resuscitation, and stroke, to support hospitals across departments and focus areas. These quality improvement programs, they are evidence-based and designed to improve treatment and prevent future cardiac and stroke events. We support your hospital's goal to provide excellent patient care by promoting consistent adherence to these latest scientific treatment guidelines. Get With The Guidelines puts the expertise of the Heart Association to work for hospitals nationwide, helping ensure patient care is aligned with the latest research, evidence-based guidelines. And your hospital, Washington Hospital Healthcare System, actively participates in our Get With The Guidelines coronary artery disease and Get With The Guidelines stroke programs. The Heart Association is pleased to present several prestigious awards this evening for outstanding quality stroke and cardiac care delivered by your hospital to the citizens of Fremont. Based on your 2020 data, your hospital earned the 2024 Get With The Guidelines Coronary Artery Disease STEMI Receiving Gold Award and Target Type 2 Diabetes Honor Roll, and the 2024 Get With The Guidelines Stroke Gold Plus, Target Stroke Elite Plus Honor Roll, Target Type 2 Diabetes Honor Roll Awards. We congratulate all the members of your clinical team and the magnificent work they do every day. I'm going to go ahead and start with the STEMI team first. So led by Dr. Segal, your chief of cardiology, Dr. Lin as your medical director, the STEMI cardiac team continues to provide stellar care for patients since joining Get With The Guidelines in 2020. I'd like to celebrate Washington Hospital for achieving the American Heart Association's Get With The Guidelines Coronary Artery Disease STEMI Receiving Gold recognition for its commitment to offering rapid, research-based care to people experiencing a specific type of heart attack known as an ST elevation myocardial infarction or a STEMI, also known to be the more severe and dangerous than other types of heart attacks. Recognition as a STEMI receiving center is designed to showcase hospitals that provide 24/7 support for STEMI, and these important facilities coordinate with a network of referring hospitals and emergency medical services to provide guideline-directed STEMI care. Next, we'll talk about stroke. Led by your stroke medical directors, Dr. Rose and Dr. Kalsa, and Maria Nunes as your stroke program manager, the stroke team continues to exceed the bar for stroke care since joining Get With the Guidelines Stroke in 2006. On behalf of the Heart Association and Get With the Guidelines program, I'd like to congratulate Washington Hospital for achieving another year of stroke accolades, and tonight there are several. The Get With the Guidelines Gold Award recognizes hospitals that treat 85% of eligible patients according to the AHA's recommended guidelines for 2 or more consecutive years. The Plus Award requires additional data collection for a set of quality measures at 75% or above compliance. The Target Stroke Elite Plus Honor Roll is presented to a very exclusive group of hospitals both in California and nationally, that treat at least 75% of their acute stroke patients in 60 minutes or less, providing the patient the opportunity to receive a clot-busting drug, which has been proven to improve outcomes for the stroke patient if given within a short time after symptom recognition. Cardiovascular disease is the leading cause of death and a major cause of heart attacks, strokes, and disability for people living with type 2 diabetes. The Heart Association and the American Diabetes Association have launched a collaborative landmark initiative called No Diabetes by Heart to comprehensively combat the national public health impact of type 2 diabetes and cardiovascular disease. Lastly, I'm honored to recognize both your STEMI and stroke team for achieving the Target Type 2 Diabetes Honor Roll geared towards the management of diabetes treatment for heart attack and stroke patients. Yet with the guidelines, we emphasize a multidisciplinary team approach to patient care. So in addition to the stroke and STEMI team leaders previously mentioned, I'd like to extend our gratitude to the countless stroke champions and STEMI champions in the ED, ICU, cath lab, telemetry, 6 West nurses, radiology, and executive physician and nursing leadership that are highlighted here today. This recognition reflects not only the hard work and dedication of the team, but also the collective commitment to providing exceptional care to improve the quality of care for your stroke and cardiac patients. I'd also like to recognize your EMS colleagues, as they are a key in the system of care, and their pre-notification is a critical factor in achieving good patient outcomes and ultimately recognition. In addition to each hospital staff's touch point with the patient, the system of care plays an important role for patients to receive the best care. Get With the Guidelines captures key metrics for every step in the patient care process, from EMS to in-hospital to discharge, to ultimately having the greatest impact of care. Both Get With the Guidelines coronary artery disease and Get With the Guidelines strokes supports the overall system of care, which is critical for reducing mortality and morbidity, as well as improving overall quality of care and cohesion throughout the healthcare continuum. Time is muscle and time is brain, and we all know everyone wants to do their part to improve a patient's outcome, whether your team is involved in the rapid pre-hospital care or the ED team working to decrease overall door in or door out times, or the STEMI or stroke coordinators reviewing how to continuously improve the overall process to help ensure consistency in patient care and outcomes. Everyone has a very meaningful contribution to the entire patient's care process, and the patients and families in your community are incredibly thankful for that. We are here to celebrate the hospital team's achievements in stroke and STEMI care. But if you are a community member attending tonight's meeting, did you know that Get With the Guidelines is more than just a data registry? In the last few minutes, I've mentioned that Get With the Guidelines is a quality improvement program rooted in evidence-based care practices that impact hospital readmissions, outcomes, death, and disability. But did you know the patients entered are not only data and numbers? They're your family, they're your friends, they're your neighbor, they're your colleagues. Their data and numbers tell you a story within Washington Hospital, stories of resilience, stories of survival, patient experiences, and the contribution of excellent care provided by the hospital's multidisciplinary team. And that's truly something to be proud of. If you'd like to learn more, our Heart Association websites, they're filled with fantastic resources, ready for you to use whenever, wherever, for public community education, awareness, and patient education. We're continuously updating information on new education opportunities. Also, as in prior years, your award will be recognized on our American Heart Association website and included in the America's Best Hospital edition of US News and World Report, and also recognized at our national conferences such as Scientific Session and International Stroke Conference. Now it's my pleasure to present the 2024 Get With the Guidelines Coronary Artery Disease STEMI Receiving Gold Award and Type 2, Target Type 2 Diabetes Honor Roll, and the 2024 Get With the Guidelines Stroke Gold Plus, Target Stroke Elite Plus Honor Roll, and Target Type 2 Diabetes Honor Roll Awards to Washington Hospital Healthcare System. Thank you so much for your outstanding commitment and dedication to quality stroke and cardiac care. Thank you so much for all you do to save lives and improve outcomes for the patients and families you're privileged to serve in your community.
Thank you, Joanne. I just want to take this opportunity to pass on my congratulations to the whole cardiology team and the stroke team and the diabetology team, and everyone who's been part of this. I think it's a great honor. Thank you so much. When I was reading this award, I was just thinking, instead of the Coronary Artery Disease Award, I think it would have been much better if it read Preventing Coronary Artery Disease Award.
Yeah.
Thank you so much.
Thank you.
Congratulations.
Thank you.
Okay, now we can move on to...
Yes, now we can move on to the medical staff report. Dr. Mark Saleh. On. Yeah. There he is.
There I am. Wow, that is very impressive. Congratulations to Washington Hospital and all the teams involved in these well-deserved accolades. Very, very impressive. Good evening, everybody. My report is going to be nice and short. The trauma program has been going since July 1st, and it's going well. There's always going to be some little tweaks that have to be done. The OR is trying their best to accommodate the increased load in work, and that is something that is ongoing, but they're doing an excellent job. We will be changing our radiology group, the teleradiology group, to StatRad September 10th. So that is coming up. And also September 10th is a general medical staff meeting. So I'll keep you updated on how that goes as well. The medical staff is working on a medical staff luncheon next month as well. That is something that we've decided that if possible, every quarter we would like to do some sort of celebratory luncheon to show our appreciation for the medical staff. We're still working on a theme and the type of food that we will bring. That's been a big hit to do something before the holiday luncheon in December. And then I think the other thing that is still upcoming in the next few months is the general surgery residents will be joining Washington Hospital and rotating here as of January of 2025 from San Joaquin Hospital from that program. Any questions for me?
No? All right.
That's all I got. Thank you.
Thanks, Mark.
Thank you.
Thank you.
So move on to the service league. Vijay.
I want to make sure I wasn't muted because you have to remind me every time. Good evening, members of the district board. Warm greetings from all the volunteers. I'm pleased to report that for the month of July, 234 service league volunteers contributed a total of 2,809 hours to the hospital. On July 11th, the service league had a table at the Fremont Summer Concert. Many attendees stopped by, picked up brochures, and expressed interest in volunteering at our hospital. We had a sign-up sheet which prompted many of them signing up on the spot, so we've been contacting them. We recently had our $5 masquerade sale. We typically hold our sale in May, but this year it was on July 29, 30, and 31st. We are happy to announce that the sale generated revenue of $6,488 for the service league. Today, I'd like to share a recent experience that highlights the positive impact of our volunteer efforts in patient care. Recently, while training a new volunteer in the infusion center, I visited a procedure room and had the opportunity to speak with a patient and her husband. During our chat, they proudly showed us a picture of their 15-month-old grandson. To extend our care, I offered the couple a knitted sweater and beanie for their grandson, which they much appreciated. They jokingly mentioned that it might fit his Snoopy plush better since he might be way too chunky for it. They were very delighted with the colorful beanie, though. Touched by our gesture, they praised the volunteers and insisted on making a small donation to our fund. Even though I explained that these items were gifts from our volunteers, they insisted on contributing. I graciously accepted their donation on behalf of the Service League and promised to send them a thank you card, which I have done so already. I didn't do it when I wrote this report, so I've done it since then. This interaction beautifully demonstrates the beautiful connections we build through our volunteer efforts. That's the end of my presentation. Please let me know if you have any questions.
Thank you, Sheila.
Thank you.
Thanks. So, move on to the lien report.
Yes, we're going to have the lien report is next, and I want to just introduce Sarah Gemsky. Since October of 2020, Sarah has been serving in the executive director role of Washington Hospital Healthcare Foundation, where she and her team raise millions annually to support various programs and services at the healthcare system. Prior to joining Washington Hospital, Sarah served as a senior director at CCS Fundraising, where she led nonprofits through strategic planning processes and fundraising planning for annual operations and campaigns. Sarah has also served as a philanthropic consultant with Rockefeller Philanthropy Advisors, where she led the research and creation of thought leadership initiatives related to philanthropic strategy and organizational effectiveness. So thank you, Sarah, for joining us, and we look forward to hearing your report.
Thank you, Kimberly, and good evening to everyone and to the district board. Kimberly, you're going to be a pro at saying philanthropic 10 times fast.
It's a mouthful.
Great. So I'm going to quickly share my screen here. And I'm grateful for the opportunity to speak a little bit about the Charitable Foundation and how we work and our goals for the year to come. Can you all see my screen okay? Great.
Yes.
Wonderful. All right. So, we've talked a lot about philanthropy in healthcare over the past few years and many years prior, as you know, that Angus was in my role prior to me joining. Philanthropy has become such an important part of healthcare. You all know the reality of healthcare these days, with expenses increasing, with payer mix changing, with reimbursements, reducing, and philanthropy becomes an increasingly important leg for any healthcare organization to stand on. You know that patient revenue is important, investment income, refinancing debt, and the more healthcare evolves, the more philanthropy will be playing an important role. The average operating margin for hospitals in the US last year was about 3.3% per month. Philanthropy can continue to play a role in really filling those funding gaps and helping to create a stable revenue stream for any healthcare organization. And you also see a really high return on investment for philanthropic dollars. Ultimately, for every dollar invested in philanthropy, they say that returns about $5 in patient operating revenue. So there's a lot of benefits there. So we've talked a lot about the financial benefits of philanthropy, which are clear, right, and kind of filling that funding gap. But aside from financial benefits and supporting the growth of healthcare in our community, there's a lot of additional benefits that we don't always talk about. And it's really going to be our priority over the next few years to come to kind of build out some of our programming so we can have a greater support on the hospital's efforts. We've talked a lot about gratitude today in our culture and the effect of expressing gratitude on one's physical and mental health. And this is no different for patients at a hospital. When a patient is given the opportunity to express their gratitude to a physician or to a provider, it often shows, studies from the general hospital psychiatry show that this has significantly positive impacts on a patient's outcomes, reduction in stress and fatigue, improved mood and sleep quality, and often this results in the patient better adhering to the physician recommendations and a reduction in their anxiety and depression. We give patients our opportunity to express their gratitude through our Grateful Patient program, which we call our Honor a Caregiver program. And there's a lot of opportunity for us to further grow that program and partner with physicians and staff members to really help this expression of gratitude be a stronger part of the culture here at the hospital. And obviously, philanthropy and expression of gratitude have a really significant impact on clinician and provider health. When a patient expresses gratitude to a physician, it really helps them, see the full impact of their day-to-day work. Studies show that this can reduce exhaustion and burnout, increase job satisfaction, sleep and eating habits, and even other physical ailments such as headaches. So a little background on who we are and what philanthropy really looks like at the hospital. Most of you are very well versed in Washington Hospital Healthcare Foundation. We've been around since the early 80s. We have a team of 4, and our overall goal is to really help further the mission of Washington Hospital through philanthropic revenue and building strong connections and lasting connections with community members. And we do this in a number of ways. We have capital campaigns that we manage every few years. We're in one now, which I'll talk about in a few minutes. We work with, really high capacity individuals in the community who want to make transformational gifts to the hospital. We also have an estate giving program, our Legacy Society, and a Grateful Patient program as well, which I just mentioned. And of course, we have a number of events every year, Top Hat being one of those, which is coming up on October 12th. Philanthropy has many important constituents, and this is really what makes our job so challenging at the foundation. Obviously we have patients, we have families of patients that we work with, we have staff, we have physicians, we have community members, we have political affiliates, we have business owners, and each one of those groups of individuals has a different way that they want to be engaged with, and they usually, have a different pathway to what they need in order to end up making a gift to the hospital and to have a strong relationship. And on average, it takes about 7 touch points from meeting an individual to getting them to the point of making a gift. So we call this the donor life cycle, and it usually takes, about a year from meeting someone to getting to the point of making a significant gift to any number of causes at the hospital. Here's a little snapshot of how successful philanthropy has been since the foundation's inception. You'll see in 2024 already, through the foundation's annual and mid-year disbursement in April, we've already dispersed over $6.7 million to the hospital, which brings our total contributions over $30 million, and we are just getting started. So one of our initiatives that I mentioned is a capital campaign to help expand the UCSF Washington Cancer Center. Most of you know the Cancer Center has been open since 2017, and since then the patient numbers have really increased dramatically. So back in 2021, the hospital approached the foundation to kind of discuss what the potential would be to raise philanthropic dollars to help offset project costs for this. We initially landed on an amount of 10 million, and we hit the ground running with a campaign back in 2022. And in February of this year, we surpassed our $10 million goal early than anticipated. So we went ahead and did the right thing of setting a stretch goal for $12 million. And we are 10.5 million of the way there, with the goal of reaching kind of our final milestone by the end of the year. So thank you to all of you who've been a part of that. It really takes a village, and we are almost near the finish line. Any campaign, especially one of this size, which is the foundation's largest, requires a lot of strategy. So going into this campaign, there was a lot of planning. Number one, we knew we had to really expand the group of supporters that we partner with for the foundation. We've had a lot of people, many of you included, who've supported the foundation year after year. But in order to reach the foundation's full potential and reach the needs and meet those needs that the hospital has going forward, we needed to expand the group of supporters that we have. So that was really one of our focuses. Early on in the campaign, our goal was to secure a number of what we call leadership level gifts at the $1 million and above amount to really create momentum and help inspire others to join our efforts. Part of the campaign efforts were also to really build a stronger culture of philanthropy, not only in the community, but in the hospital as well, educating physicians, educating staff on what philanthropy is and why it's so important to the hospital, and really getting them comfortable about talking about philanthropy to their networks or even to their patients. And obviously, showing our appreciation to our supporters for their gift and really illustrating the impact of their giving. We call that stewardship. So that's been really one of our priorities, so that we can ensure that we're properly managing these relationships and making sure that our community members really see the full impact of their support. So here's a little snapshot of kind of what it looks like in any campaign of this size. If our goal is to raise another $1.5 million within the next few months, we're 87% of the way there. We started out the campaign with gifts, at 100,000 and above, which we're calling core or leadership gifts, as I mentioned. And then we moved down to major gifts and corporate gifts, which are between the $25,000 to $50,000 range. And then last December, and we started engaging our physicians. And then just in late June, we started engaging our employees at the hospital. And our employees have always been such significant supporters of the foundation. For the last campaign for the Morris Hyman Critical Care Pavilion, we had about 60% of our employees make a 2 to 3 year pledge to the campaign, which is way above average. So we have a lot of support from our staff, and we've seen that already for this campaign so far. And then just last week, we officially launched the public phase of the campaign, which you do when you reach about 80% of the campaign goal. We have ads on KQED. So if you listen to KQED in the morning or the evenings, you'll hear an ad about the campaign and the Cancer Center. So we are getting there. But the challenge is that for the higher gift levels, you need fewer of them. And typically the ratio is, if you need 10 gifts, you'll need to speak to 2 times or 3 times the number of individuals in order to make sure that you can kind of secure the gifts that you need. And when we go down to the gifts that are below 10,000 and even gifts of $100 or $500, we really need a lot more in order to make our goal. And that means talking with a lot of people. So that's kind of the phase that we're in now. We're doing a lot of public outreach. We're partnering with our community to get in front of local Rotary groups, Lions clubs, things like that. We're tabling at community events in partnership with Angus's team and Kayla. So when it comes to kind of the lean or Gemba activities, this slide, I think, really illustrates the full picture of what we do on a day-to-day basis and what makes this campaign so special. I mentioned it takes about 7 touch points to move an individual from when they make a gift to when you meet them to when they make a gift. And we classify them in 4 different phases, really. When you first kind of hear about the individual, when someone mentions their name, we classify that as the discovery phase. So we do a little research about them, figure out how they're affiliated with the hospital. And then, once we start to engage them through, if they're attending an event, if they're meeting with a physician, we call that the cultivation phase. So we're learning more about their interests and trying to get them on board with the hospital's mission and vision and talk about the impact of philanthropy. Once we successfully identify an area of interest that we have, we put them in the solicitation phase, which means they're ready to be formally asked for a gift. And once they do that, then they're in the stewardship phase, which is just constant check-ins, every month or so to really keep them updated and keep them engaged with the impact of their gift. So over the course of the campaign, you'll see how this colorful rainbow is really changing. Not only are we engaging new individuals, that's that light green line at the bottom, but we're moving them through. So you'll see the different sections really changing. In the middle of the campaign and from the beginning, our goal was to really expand that donor pool. But as we get to the later phases of the campaign, our goal is to really close those gifts. And if people really aren't interested in cancer specifically, we're just going to kind of take them off our outreach lists and maybe move them to another priority. So you'll see some of the areas changing. But this is really all the relationships that we manage at one time to get us to these different milestones. And then lastly, what does the future of philanthropy look like at the hospital? Going forward, it's the foundation's goal and the hospital's goal as well to help the foundation have a bigger impact on the hospital's future. Our goal is to really identify specific needs within the hospital's key service lines that we can impact. So potentially choosing 2 or 3 priority service lines per year and making a goal of raising, $1 million, $2 million per year to support either operating costs or capital needs, and equipping the philanthropic staff with the kind of the language they need to go out and say, hey, this is what the cardiology program looks like 5 years from now. This is where our goals are. On a 1-year basis, this is what we need to get there. And that really would give them the tools to make those solicitations and to secure those gifts and to have a constant revenue stream coming in for the hospital. So, we're in discussions with hospital leaders about kind of moving to that direction and figuring out how philanthropy can continue to play such an important and central role within the hospital. And also just building a culture of philanthropy, as I mentioned, creating awareness about who we are and the impact of philanthropy, building stronger partnerships with physicians, with staff, with community members and local businesses, and really also supporting the hospital's mission of educating the community about the high quality healthcare services that they can access right at the hospital. So that is all for my presentation this evening. I appreciate your time, and I wanted to pause to see if there's any questions about all that we do at the foundation.
Thank you, Sarah.
Thank you.
Thank you, Sarah.
Thank you.
Thank you very much.
Thank you.
Next,
Quality.
yeah, next we're moving on to the quality dashboard, and we have Mary Boron, our Chief Quality Officer, and she'll be reporting on the quarter ending June 2024.
Correct. Thank you, Kimberly. The other thing that we're going to be doing, it's a little different on tonight's report, is because this is the last quarter of the fiscal year, I will be telling you sort of a overall fiscal year summary of the data for each one of the metrics, just to give an idea of where we ended up for the fiscal year. So starting in with our infection prevention indicators, we have MRSA, which I'm happy to report we did not have any infections this quarter. We had this sort of uptick in about the winter of the end of last year and a little bit in spring. And we've done a lot of work around this with looking at prevention for transmission-based bugs such as MRSA. And again, it's continuing to focus on using our hand hygiene to break the chain of infection and prevention bundles for spreading infection into the blood. So again, happy that we didn't see any of this quarter. Then moving on to our catheter-associated urinary tract infections, otherwise known as CAUTI. It was lower than the predicted number of infections for a hospital of our size and type, but we had one CAUTI. This sort of broke this streak of a lot of great success, and we still continue to have success around this, where having less than expected CAUTIs. But even one we do take serious. And what we're looking at with this one happened on one of our predominantly surgical floors, and we're just looking at the use of external catheters, and we've used those for a long time, but making sure we use them whenever possible, and of course making sure that the catheter is removed as long as it is no longer medically necessary. If it does need to stay in the patient, we really have a lot of detailed root cause analysis when we do have a CAUTI, looking at how well was the catheter maintained? Did we keep the area clean? And were we keeping the bag in place where it needs to be? So all of those things go into our root cause analysis and went into this one case, and we'll be applying them into future prevention for CAUTI. Our CLABSI, happy to report, we have continued our streak here with 0 CLABSIs. We have not had one in 821 days, about 2 years and 2 months. So very happy to report that. Again, it's the same sort of thing where we have to have strict adherence to our bundle that prevents CLABSI, which is making sure that when the line is placed, it's placed with aseptic technique, and then it's maintained very well afterwards. And again, just following standard infection prevention methods such as hand hygiene, et cetera. So that is a real great success, and it is a multidisciplinary team that continues to help us maintain this. It is technically a nursing sensitive indicator, so a lot of credit goes to the nurses who are maintaining these, but we also have to look at how they're placed and everything. So it's everybody on the team, really. Our surgical site infections, we did have 0 again. So this is another successful metric where we've been able to sustain an outcome with a procedure that is at high risk for developing surgical site infections, which is one of the reasons why on even a federal and state level, we're required to monitor this surgical procedure for surgical site infections. And this is also a reflection of making sure that when the patient comes into the OR that we're using strict aseptic technique, also following really appropriate timing of antibiotic use, and maintaining the insertion site well, especially in the beginning. So this one follows up for up to 30 days afterwards. So great job there to the OR staff. And same thing here in abdominal surgeries. We did not have any surgical site infections related to hysterectomies, another procedure that is required on a federal and state level to monitor because it is high risk. And we have had a long string of 0 surgical site infections for all of the same reasons that I just mentioned. So that team continues to do really well with this metric. C. diff, we did have 2 infections this quarter. That is significantly lower than what's predicted for our hospital in size and type. It's predicted that we would have about 9, so we had far less. Again, we do even take those 2 very seriously. Every C. diff infection has a root cause analysis done to make sure that we were testing the stool appropriately, and did the patient have any history of antibiotic use that may be inappropriate, et cetera. In these 2 cases, that was not the case. These are C. diff infections that show up with 72 hours after the patient's been admitted, and we do have a very strict algorithm that we follow with these. And in these particular cases, the patient was symptomatic and tested 72 hours after admission and turned out to be positive. But again, we didn't see anything that was transmission based for spreading the C. diff, et cetera. And also still a successful metric that we've been able to sustain for well over a year and a half. Our hand hygiene data continues to hold strong. We had a compliance rate of 97%. That's higher than the goal, which is 90%. We do have two goals on here. We have a World Health Organization goal, and their benchmark is 70% because they, of course, recognize they have probably got the biggest pool of research on this data, and they recognize that this is a challenge in healthcare for healthcare workers washing their hands. And so they've set it at 70%, Joint Commission's higher at 90%. So us sitting at 97% is great, especially considering the volume of these observations that we're doing. In April of this year, we did implement a new unit-based model and had a lot of great support from all different members of the team to collect data on their unit. We now use an electronic model, and so it's easier to sort of collect it. So we've been able to get a larger number of observations and have had, like I said, support all the way up from the unit level to the CEO on supporting us on making sure that we have the right resources available to do a lot of observations. And it's come out to be really well. And again, this is the best way to prevent the spread of infections in the hospital. Very happy to see this at 97%. So for the roll-up for the fiscal year, out of these metrics, we actually did meet for 5 of these 7 that were met, and this should this one across from C. diff should be green. So it's technically 5 that we met for out of the 7. We did struggle, as I mentioned earlier, with MRSA, and with the MRSA, it's a reflection of 5 infections over the year. And so we took that very seriously and went in and did root cause analysis, got together a subgroup team from Infection Prevention Committee, really looking at this. So going into this fiscal year, we know MRSA is something that we want to watch very carefully. Again, this is MRSA in the blood. This is also 72 hours after admission. So it does seem like in the last quarter it's come down, which is great, but we'll continue to watch that. Overall, though, a great level of success here. The hand hygiene, as you saw, only missed by slightly. I mean, if we had a couple more observations in there, we probably would have been able to turn that green, but the numbers are the numbers. And so it's the hand hygiene, though, as I said before, I don't have as much concern about. We'll watch MRSA closely. And C. diff did meet goal. And moving into our nursing sensitive indicators, we look at patients that fall in the hospital, and this is any fall that happens in acute care. So it's any unplanned descent to the floor. And this quarter, we did not meet the goal. We were slightly above the goal. The goal does lag a little bit on the national database that we use. So we go off of the prior quarter, which is 0.57. And this quarter, we were at 0.64. This is a reflection of 10 falls. And patients did have some injuries. 9 of those had very minor injuries, abrasions. We did have 1 hematoma to the head after a fall. All of these were looked at. We get a very good summary from nursing on these that they send over to quality, and we work and look with them at the patient populations. The falls prevention team is doing a great job at looking at the root cause analysis on all of these. What's interesting about this particular group in this quarter is the ages ranged. Typically, you will see it's 65 and over, and in this particular quarter, our ages started at 21 and went all the way up to 72. And the fall that we actually had to the head was a patient that was on the younger side. This was a 44-year-old. And these were sort of dealing with issues around substance abuse, and there was confusion, patient getting up, trying to go to the bathroom. So again, a younger group this quarter, but they were all on fall prevention. A couple of these patients who fell did have their bed alarms on, et cetera, but just got up and were trying to go to the bathroom and fell. And moving into our hospital-acquired pressure ulcers. So the way that we collect this data over a quarter is we randomly do what we call point prevalence, which is sending out healthcare workers that are trained to observe patient skin and to look and see what category of a pressure ulcer a patient may have. And in this particular quarter, we had 102 patients that had surveillance with this trained group. And out of the 102, they did not find any pressure ulcers. And again, pressure ulcers, otherwise known as bed sores, to find 0 out of 102 is a great success for our nurses and this nurses sensitive indicator. Of this category 2 type of ulcer, it would be something where the patient has something a little beyond the redness. So again, this is looking at everything from a redness to a patient to skin breakdown to all the way into the fatty tissue and the muscle. And we didn't have any of that in all 102 of those patients that were observed. So the message from that is that these patients are being turned appropriately. They are on the right mattresses. We try to watch their nutrition carefully because that, of course, puts them at higher risk for developing bed sores, and saw 0 of those. And for our roll-up for this year, we, out of the 2 nursing sensitive indicators, we missed one barely, and it was the falls, like I spoke about earlier. This is a very strict low benchmark for a magnet hospital, and I'm confident that as we go forward, that will be green. And again, it just barely missed. And good success for our pressure ulcers overall for the year, meeting the goals. And moving into our readmissions, overall, we have a successful quarter here, starting off with patients who were admitted to the hospital with having an AMI or a heart attack, where our rate of readmissions was 11.8. The CMS national benchmark for that is 14%. So that's a reflection of 2 patients coming back within 30 days of being admitted to the hospital. Both of these patients were admitted, did meet medical necessity, but it was not related to their AMIs. So those were patients that needed to be here. And again, we've seen this metric kind of go up and down, but for this quarter, it was under the benchmark. Pneumonia had been a big challenge for us, and so we had put really a lot of effort into reducing pneumonia readmissions. And as you can see, we are on a steady decline in those, I'm happy to report. This particular quarter, our readmission rate for pneumonia was 6%, which is significantly lower than the CMS national benchmark, which is 16.9%. So that's a reflection of 4 patients that came back. And again, because this has been a challenging population for us, we look at even those 4 patients really closely. We did have some issues with medication management on 2 of those patients, and kind of had some lessons learned about that. And it was the follow-up on making sure that they got their antibiotics. We review all these cases to see, did they meet for medical necessity to come back? And all 4 of them did. So rightfully so, they need to be admitted to the hospital. And then heart failure, another metric that it kind of is continuing to go up and down. For this quarter, our readmission rate for heart failure was 20%. I mean, technically it is lower than the CMS national benchmark, but which is 20.2. So we did meet the goal, but it was slightly. It's a reflection of 7 patients that came back. And these patients all had, well, I should say 6 out of the 7 of these patients were dealing with other chronic issues, which is what we often see in heart failure and COPD. And for these patients, they did meet medical necessity, and there were issues around chronic illness. I mean, there were some neuro issues and other issues that related outside of heart failure. But those are patients that we really need to watch to make sure that they're getting to their follow-up appointment, because a couple of these did not. And so we've put a new system in place with our transitional care team for sort of trying to automate follow-up appointments and make sure that they're made prior to discharge, not just that the patient is going to plan on making them after the patient leaves, that we help them make that follow-up appointment, and we have help them come up with a plan for how they're going to get to it. Because it's really important that they're watched, especially in the first week after they leave the hospital in this chronically ill population. Similar things apply in COPD. And then this quarter, we had a rate of 22.2%. That is higher than the CMS national benchmark of 19.3. It reflects 4 patients that came back. Very similar story as what we're seeing in heart failure. Chronically ill. 2 of these patients, actually, we had some discussions with on palliative care and introducing the idea of the patient to maybe move towards palliative care. Those patients were very sick, all 4 of them. And we know and recognize that not all patients are ready to move to palliative care immediately, but it's always good to give them an opportunity to hear about palliative care services. And we are working closely with the palliative care team. Our leader in transitional care is just starting to do that, because I think that it's really important that these patients hear about palliative care for the sake of the quality of their life and management of symptoms. So we really want to work on that coming into our new fiscal year, about working with the palliative care team. Coronary artery bypass graft, otherwise known as CABG. This was a good result for us. We did not have any patients readmitted, so our rate was 0%. The CMS national benchmark for this is about 11%. So out of 7 procedures, 0 came back. And other than that time that we saw it in last quarter of 1, we've now gone multiple quarters where CABG seems like it's being managed well. There's a good discharge plan, and we haven't had too many problems around that with readmissions recently. And our patients that have inpatient elective hip replacements and knee replacements are another population that is monitored by CMS. We had 0 of those patients come back. This is not a procedure that's frequently done inpatient anymore. And so that's why you see that there were only 8 patients to begin with in this group. But the good thing is 0 of them came back. And the reason why these patients are inpatient, the small group of 8 patients, is typically because they need something monitored closer. They may have had a history of hypertension or some chronic illness. And so we have them come in, stay in the hospital, and be monitored closely as an inpatient. So they tend to be sicker and higher risk. So it's good to see that none of them had a readmission. But if you move into our next slide, which is the patients who had outpatient surgery, which is where the bulk of our patients have their surgery, is outpatients who are getting their knees and hips replaced. We only had 3 readmissions. That puts us at a 0.9% readmission rate. The national benchmark for this is about 4.3%. So out of 317 patients who had an outpatient knee or hip replaced here, we only had 3 readmitted. Those cases were observed. All 3 of them had nothing to do with why they did not come back related to their surgery. I want to be clear about that. It was other issues, medical issues, and they were all of them were over the age of 70. So our roll-up for readmissions is actually very good this fiscal year. As you can see, we met 6 out of the 7 goals for readmissions. And it's interesting because we were always thinking, oh, it's going to be pneumonia, and it wasn't. Probably because, like I said, we made it a focus group. AMI was slightly above at 15.3%. And the thing about all these populations, especially the medical ones, is that they all really benefit from the same level of interventions. And so in moving into this fiscal year, it's really a bundled approach. We want to treat all these disease states similar. We've learned certain things, like I said, about heart failure and COPD, especially related to maybe some earlier palliative care referrals. But in general, we want to make sure that these patients really understand their discharge plan prior to leaving, that we help and support them in making sure that they follow up with their doctor afterwards, that they have the right medications, that they actually have a place to pick up the medications and they know how to use the medications, and that they get to a doctor soon after being discharged from the hospital. And we really want to make sure that we're offering them that type of quality transition from acute care on to wherever their next continuum of care may be. It may be in a SNF, it may be home, it may be home with home health. Interestingly enough, one of our largest contributing groups is patients that come back from a SNF because they are sick, tend to be sicker and can't go home. And so we are working in this new fiscal year closely with our SNFs, and we have a certain group of about 5 skilled nursing facilities that we're actually meeting with and going over the readmission data with frequently, and working with their medical directors and their leadership there to help to make sure that these patients, even when they're at a SNF, have proper quality care and are meeting national standards so that they don't have to come back and be in acute care unnecessarily. So that'll be our focus moving forward. Overall, though, a lot of improvements in readmissions in the last year. And thank you.
Thank you.
Any questions for Mary?
No? Results. Okay, Mary, thanks.
Thank you so much.
you.
Go to finance?
Yeah, next we're going to move on to the fiscal year, the end of the fiscal year, but the June financials, and Tom is going to present them.
So normally I'd say I'm happy to present the final numbers for the month. I can't say that for June because, as you know, they're not final until the audit is completed and presented to you in December. I will say that June was another one of those months where we had some positive things and some ongoing challenges. And so with that, I'll start running through the numbers. For the month of June, our inpatient average daily census was 147.6 off a budget of 166.2, so a miss by about 18.6. Our discharges were 820 on a budget of 956. And our patient days of 4427 were short of budget by 559, and the budget number was 4986. Outpatient observation equivalent days came in at 346 on a budget of 284, so that's a miss of 62 for the month. And then our average length of stay was 5.11, which is under the budget, positive, of 11 basis points. And when I say June and the fiscal 24 year had some challenges, you can see on the right side of the chart, for the year, the inpatient average daily census, we missed budget by almost 8 days. Or excuse me, 8. And then combined average daily census was a miss by 6. We were 1,000 discharges under our budget. Our patient days, we were short by 2,900. Our observation equivalent days exceeded our budget by 658, so that's a miss. And then average length of stay came in at 538 on a budget of 523, or over budget by 0.15. On the operating indicators, for the month of June, our case mix, or CMI, was 1.63 on a budget of 1,488. On the year-to-date, we're at 1,593 on a budget of 1,542, so are seeing a little bit of higher acuity from our patients. Deliveries for the month of June, 95 on a budget of 123. And on a year-to-date basis, we came in at 1,464 on a budget of 1,536, or a shortfall of 72. Surgical cases for the month of June came in at 446 on a budget of 467, so 21 shortfall. And then on a year-to-date basis, we exceed the budget of surgical cases by 26. The one thing I will point out there is in fiscal 24, we added endoscopy to surgical cases, and a lot of that increase is due to the endoscopies that are now performed and counted in that number. Cath lab cases for the month of June were 194 on a budget of 201. And for year-to-date, 2128 for cath lab on a budget of 2404, or a miss of 276. So again, an improvement over fiscal 23 when we were 2 physicians down, where that miss for the year was over 500. But we did lose one of the 2 physicians, as you know, about halfway through the year. So, outpatient visits, 8139 on a budget of 8479. So a shortfall of 340 for the month. On a year-to-date basis, however, actual exceeds budget by 2,074, coming in at 103,069. Emergency visits for the month of June came in at 5,006 on a budget of 5,154, a shortfall of 148. On a year-to-date basis, it's a lot tighter. We came in at 60,723 encounters on a budget of 60,792, or a shortfall of 69. So here's some detail on the surgical and cath lab. So you'll notice that under the orthopedic cases on surgical, shortfall of 34 off budget on a 153 on a budget of 187. And again, just as a reminder, Dr. Alex Saw had moved some cases starting in January over to the WASC. And so that 34 is about what Dr. Saw performs on a monthly basis over it. On the cath lab, you can see 194 on a budget of 201, with peripheral vascular short 21 of 51. And again, this is where one of the physicians that we had brought in didn't work out and left us, and that's the area where that volume would have been. On the next one, the operating indicators and productivity. Looking at the combined numbers, total FTEs for the month of June came in at 1620.6 on a budget of 1675.8, or positive by 55.2. On a year-to-date basis, it tightens up a bit, 1640.3 on a budget of 1656.1, or about 16. And these are now budget numbers, not flex budget numbers. Total FTEs per adjusted occupied bed for the month of June was exceeded budget, which is a negative, at 6.4 on a budget of 6.14, or by 26 basis points. On a year-to-date basis, however, we are 22 basis points better than the budgeted number. So now getting into the financials a little bit deeper on the summary of deductions. Gross revenue was $190,542 on a budget of $196,219, or about a $5.7 million shortfall. Contractuals were $143.8 million on a budget of $145.6, bringing our percentage to 75.5 in the month of June versus a budget of 74.19. Moving on down the line, to the next row, for provision of bad debt and charity, we have $2.6 million actual on a budget of 3.6. So pickup of $1 million on that. And then about 1.35% of revenue versus a budget of 182. Total deductions then are $146.4 million on a budget of 149.2. Bringing our percentage deduction to 76.85 on a budget of 76.01. If I move us straight along that bottom line, year to date through June, so fiscal year unaudited, we came in at 76.94 on a budget of 76.34. So as the board knows, as we go into the summary of operations, our fiscal 24 started off the first 3 months rather difficult. We had pretty low volume and some high expenses due to flexing, staffing flexing, and other contracts that were being renewed. The executive team met to discuss ways of improving operations and the operational results. A handful of initiatives were identified, which included establishing OIPs, or operational improvement plans, for those departments that needed help flexing to the volume. It also included setting early retirement window from the pension plan, pausing travel, pacing our capital spend out over the course of the year, and then vendor contracts, just to name a few of the things. And while these did help, as you'll see in a moment, they did not resolve the strain that was on our financials over the course of the fiscal year, and I'll go through that now. So on the fifth line down, under net operating income for the month of June, we finished at $707,000 on a budget of $672,000. However, on a year-to-date basis, we wound up the year with negative, or a loss of net operating income of $3.3 million, Our budget was 11.7, so it's a $14.9 million shortfall from budget.
Yeah, I think you went to, you went to FASB. I was just, now you're back in GASB. Okay.
We're on GASB.
Yeah.
Yeah.
The slide switched on the screen to.
Yeah.
Oh,
So, no.
I'm on GASB. Oh.
Okay.
You're now on the
I
right
know.
page. Yeah.
Okay, that's what I was looking at.
Three's making me look bad. No. All right. Now we're going to go down to non-op income, which is the third line from the bottom on the left. Non-operating income came in positive at $2.7 million on a budget of $91,000. So exceeding the budget by $2.6 million. On a year-to-date basis, moving on over to the right, non-operating income finished the year at $19.5 million on a budget of $4.2. So we exceeded non-op income by 15.2. The next line down is net income, where we take the non-op and the operating income and put them together. So you can see for the month of June, we came in at $3.4 million on net income on a budget of $763,000. On a year-to-date basis, net income is $16.2 million on a budget of $15.9. When we look at this from a FASB perspective, and just as a reminder, FASB does not unrealized loss on investments. The interest expense from the GO bonds, property tax revenues that we're given are stripped away from the non-op side. So from FASB, we finished the month of June at $1.5 million in net operating income on a budget of $130. Year to date, however, FASB would have us at negative $9.9 million for year to date on a budget of a positive 5.2 or a miss of $15.1 million. When we move down to the second line from the bottom for net income, you can see $2.5 million for the month of June on a budget of $550,000. And as we move across, net income actual year to date is 9.4 on a budget of 13.2. So a miss of $3.8 million.
Looks like our investments helped us a lot.
Yes.
What specific sectors worked well for us?
From the asset side?
Yeah.
Hayden is going to be here on Monday to share that information with you. But I would say the rally was broad over this period. And over the fiscal year, it's been extremely volatile. You know, the first 6 months of the fiscal year, or the second 6 months of the fiscal year. And so I would definitely say that a diversified portfolio performed very well.
We can only hope.
Yeah. Okay. So now I'll move on to the EBITDA slide. The fifth line down on the left shows that we came in at $4.45 million on a budget of 3.7. And EBITDA year to date came in at $36.4 million on a budget of 48.5. So that was a miss of about $12.1 million. EBITDA margins year to date came in at 6.4 on a budget of 8.2. The other thing I wanted to point out, even though this is the EBITDA slide, is the next line down is depreciation, and you'll notice year to date that depreciation came in about $3 million over, and that is that GASB 87 and GASB 96 when we move things out of lease or other expenses and depreciate them under the new guidelines. And with that, my report is concluded.
Yeah, and I just want to, as Tom mentioned, we continue to have some challenges on the operational side that we know we need to continue to address for this next fiscal year. And even looking, below the operational net operating margin, you did, as Sarah Gemsky talked about, the $6.7 million, that helped to contribute, but a lot of that's allocated to, for our cancer center, from specifically already allocated from that standpoint. So we do understand that we continue to have work to do on our operations to strengthen them on both the revenue and expense side. So, all right, I am going to move forward with presenting July, our first month of the new fiscal year 25. And some of these slides will be new that in terms of explaining them to you. I do want to say that July was a very busy month. It was probably, looking back the last 5 years, it was we had the highest gross revenue that we've seen. And you can see that it came in at $220.3 million for July, and it was favorable to the budget of $209 million by $11.3 million, or 5.4%, and higher than July of 2023 by 15.6%. So again, it was a very busy month. A couple of new slides that I do want to just talk about is our trauma volume. And if you look on the left-hand side, and you will then see our actual for July, and the 40 is basically, so in total we had 120 trauma cases for July, and that was favorable to the budget of 101 by 18.8%. And if you can take a look, the inpatient trauma cases of 40, and that's sort of the bluish green color there, for July was unfavorable to the budget of 64 by 37.5%. But the outpatient trauma cases of 80 for July was favorable to the budget of 37 by 116.2%. So we really saw more outpatient trauma, visits than we did inpatient from what we budgeted. And as we've talked about in the past, there's sort of 3 levels of trauma cases. And it goes Alpha, Bravo, Delta, and Alpha is the highest. And we saw 5 Alphas, we saw 61 Bravos, and 54 Deltas. So that's how the first month. And again, we looked at the budget and worked with the consultants and others, but we'll have to see as time goes on from that. The next slide goes into basically our gross revenue. So for the trauma gross revenue, came in at $12.1 million for July. It was unfavorable to the budget of $13 million, so by about 6.9%, so about $898. And a lot of that is due to the case mix. And inpatient trauma gross revenue of $7.9 million for July was unfavorable to the budget of $11.5 million by 3.6%. And then outpatient trauma gross revenue of $4.2 million for July was favorable to the budget of $1.5 million by 2.7%. So that's just in terms of us looking at those two. So wanted to just start by giving an overview of some of the trauma. Moving on to just overall our inpatient gross revenue, you can see starting on the left-hand side, we have the prior year of July, we have the budget that's in gray, and then the actual, which is in green. So inpatient gross revenue of $128.9 was favorable to budget by $4.3 million, or 3.4%, and $22 million, or 20.6% higher than July of 2023. Looking at our outpatient gross revenue of $91.4 million was favorable to budget by $7.1 million, or 8.4%. And $7.7 million, or 9.2% higher than July of 2023. So again, to show we've been much busier than the previous year. Looking at the average length of stay, it came in at 5.73, which is unfavorable to budget of 5.53 by 0.2, or 3.6%. And the average length of stay was higher than the July 2023 average length of stay of 5.46. We did look at the trauma. The average length of stay for trauma was 4.3. So excluding trauma, the average length of stay was 5.79. So it wasn't driven by trauma. It was driven by some of our longer lengths of stay patients from that. Moving on to observation equivalent days, they came in at 380, which was favorable to budget of 383 by 3 or 0.8, but longer than July of 2023 by 28 equivalent days. Now, we are working on updating this slide, and we will be doing that for next month in terms of giving a little bit more information on our observation days. Moving on to inpatient average daily census, came in at 161.6, which was unfavorable to the budget of 166.6 by 5 or 3%, but higher than July of 2023 average daily census of 152.3 by 9.3 equivalent days. Average daily census of 5.5 days was for trauma. Moving on to the discharges, July discharges of 959 were favorable to budget, 933 by 2.8%, and were 13.1% more than July of 2023. Looking at our patient days of 5,009 were unfavorable to the budget of 5,164 by 155 days, or 3%, but were 6.1% more than July of 2023. And really, we saw the ICU days were favorable to budget by 13.2%. IMC days were very close to budget. It's off by 1 day or 0.2%. Telemetry days were unfavorable to budget by 1.5%. And OBP special chemistry were below budget by 16.4%, so that's the major driver. But also med-surg was below budget by 4%. Looking at our surgical trends, total surgeries in July came in at 508. They were favorable to the budget of 478 by 30 or 6.3%, and were 10.4% more than July of 2023. Inpatient surgeries of 239 were unfavorable to the budget by 9 or 3.6%, but 25% more than July of 2023. And then outpatient surgeries at 269 were favorable to the budget by 17% and consistent with July of 2023. So then moving on to looking at the breakdown, you can see that orthopedic surgery came in 35 greater than the budget. We did have our UCSF Health ortho surgeons did do 25 cases this month, so that helped to drive up in terms of the orthopedic surgery cases. Neurosurgery cases were at 32, the budget was at 6. Cardiac cases came in at 13 versus a budget of 10. I will just definitely want to mention that we did 5 TAVR cases in this month, and we did hit 100 TAVR cases during the month of July. And if you remember our last month's discussion, it's really the minimally invasive procedure for failing valve. And then you can see endoscopies were above budget. That was also offset by other surgeries. And as Tom mentioned, endoscopy, though, has increased. It's not at the same level in terms of our surgical volume. You'll see that in the gross revenue too. The cath lab trend, July cath lab cases were 173, which were unfavorable to the budget by 7 or just 3.9%, but again was about 17% more than July of 2023. We also, as mentioned last month in our educational presentation, we did do 4 of our first Watchman cases during this time, and so that occurred at the end of July, and really that's a minimally invasive procedure in terms of helping to reduce the risk of strokes. Cath lab inpatient cases of 87 were unfavorable to the budget by 21.6%, and just 3.3% fewer than July of 2023. And outpatient cases of 86 were favorable to the budget by 24.6%, and 48.3% more than July of 2023. Here you can see in terms of the breakdown of the cath lab activity. Again, we did 10 more cardiac cases, but offset by less than budgeted non-vascular IR and peripheral vascular cases. We did see higher neuro IR cases this month by 5. So again, looking at that's improved. Moving forward with deliveries, deliveries for July were right on budget at 125. and were 16 more, or 14.8% more than July of 2023. Looking at the non-emergency department outpatient trend, we saw visits of 8,932 that were favorable to the budget by 8.4% and more than July of 2023 by 13.7%. Really driven by lab visits that were over budget by 10.8% and imaging visits that were over by 16% compared to budget. So busy again, and you'll see that with our ancillary services. Emergency department visits came in at 5,217. They were favorable to budget by 97, or 1.9%, and were 8.8% more than the prior year. We also really, that stood out, we have different levels of emergency room visits, and the highest level, level 5, which is comprehensive, and level 6, critical care. Those were both above budget significantly this month. So moving on to our gross revenue recap, as mentioned, we were above budget by 5.4%. Surgical services, though, above budget in terms of cases. The case mix was the reduction of $2.2 million in gross revenue was really driven by the mix of cases. As I mentioned, we had a high number of endoscopy cases and less neurosurgery, and also other cases. Our cath lab revenue was $1.8 million, favorable to budget, and again, due to the case mix really having a higher cardiac cases and also neuro IR cases. Room and board revenue was favorable to budget by just $56,000, or 0.1%, and then birthing center revenue was favorable to budget by 3%. It was right on that we did have a higher C-section level in the birthing center. We did see emergency department revenue was favorable to budget by $3.7 million, really given that's driven by the high number of trauma outpatients that we saw, and also the mix. And then lastly, ancillary services was favorable to the budget by $7.8 million, primarily was driven by higher utilization of the CT scanner, infusion services, lab, and also in terms of, those are the main drivers for the ancillary services. Looking at our preliminary payer mix, trauma is included in this. Government-sponsored payers, as you can see, made up 73.6% of total revenue. This was favorable to the fiscal year budget of 74.6%, though higher than the prior year's percentage by 1.3%. HMO gross revenue came in at 2.8% of total gross revenue, favorable to the budget of 1.7%. This was also higher than the prior year's percentage of 2.2% of gross revenue. PPO came in at 21% of total gross revenue, favorable to the budget of 20.9%, or very close to the budget, I should say. I also want to just mention we did break out the VA TRICARE this year. And the reason for that is, historically, this was included under PPO, but it really pays more as a Medicare. And so we wanted to break it out. It's really more aligned. The payment is more aligned that way. So that's the reason why we are breaking it out. And you can see that it came in at 0.6% of total gross revenue, favorable to the budget of 0.8%. Lastly, private pay gross revenue was 2% of total gross revenue, consistent with a budget of 2%. Though I will just say we are watching the private pay just with the trauma, and what we're seeing is for the trauma volume that is higher, because a lot with the motor vehicle accidents, they go into private pay, and as you know, that is something that we have to continue to follow up on, and a lot of it becomes a legal case. But it is hitting private pay for now in terms of it. So we do expect, and I know Tom's and Revenue Cycle is watching that from that standpoint. Moving on to productivity indicators, our total FTEs for July were favorable to budget by 69.8 to 4.1% at 1,648.8 FTEs, and adjusting for volume, we were at 60.3 or 3.5% favorable to the flex budget. So total FTEs per adjusted occupied bed came in at 5.97, and that was favorable to the budget of 6.15 by just 2.9%. So overall, just given the volume that our FTEs did come in under budget. Moving on to our outpatient statistics for witness. The clinic visits came in at 17,099. They were favorable to the budget in July by 552 or 3.3%, and were also 17.1% higher than July of 2023. Our primary care visits came in at 8,006, which were just slightly unfavorable to the budget by 21 visits or 0.3%, and 810 visits higher than July of 2023. Our specialty care visits came in at 9,093, and they were favorable to budget by 573 or 6.7%, and 1,692 higher than July of 2023. Really, a lot of that was driven. ENT clinic was very busy over this last month, and so was cardiology, were the two main drivers. Moving on to radiation oncology, we are still working on, as we've talked about, we'll have that for you next month in terms of showing some additional metrics for the Radiation Oncology Center. As you can see, we did have also a very busy month for treatments. They came in at 417, which is 5.6% favorable to the budget of 396. And this was a lot driven by our strong referrals that came in May. We had 50 at that time, and we're really seeing the impact of those referrals that turned into the treatment volumes in June and July. I will say July has been a little bit slower in terms of referrals, so some of that may play out over the next couple of months. We had 23 new patient referrals that was 5 lower than the fiscal year 24 average of 28.19, and we had 19 new treatment starts, which were 3 lower than the average of 22. Moving on to DEPCO, our DEPCO outpatient visits came in at 1,960. They were unfavorable to budget by 12.3% for July, but 17.6% more than the prior year. I will just say our Washington Outpatient Surgery Center cases were favorable to budget by 21.4%, and our Peninsula Surgery Center cases were favorable to budget by 14.5%. And this was offset by our rehab center visits that were unfavorable to budget by 23.4%, and we did have some physical therapists that were out for a number of days. So, but August is looking at stronger going forward. Looking at our key financial statistics in charity care, days cash on hand for July ended at 131 days, an increase in 6 days. This was really driven by our cash collections that came in at $8 million, which is about 6 days. We did have $2.3 million in unrealized gains, basically in investments, and that was offset by increases of $1.9 million on accounts payable disbursements. So a strong, month from that. I will just again mention here, you can see our charity care came in at $397,000, and a third of that was driven by our trauma. So wanted to just mention that. So those are, that's the preliminary financials for July. Busy month, but still working through everything with care mix and others.
Really trying to understand the impact of trauma.
Exactly. It's going to take us a few months. As I continue to say, 1 month is not a trend. We need to continue to watch it. But August has been not as busy as July, so we'll have to see where we stand with that. Can I move on to the operations and move on to the other pieces? All right, I want to talk about Employee of the Month for August, and that's Paulo Calvo. He's the biomedical electronics technician, and he is our August Employee of the Month, has both the training and the disposition to calmly and efficiently troubleshoot a problem and resolve any issue. Whether working alone in the shop, in the dialysis department next to a patient, or in the operating room under stressful conditions, Paulo maintains his calm demeanor and addresses the issue. Paulo joined our healthcare system in April of 2019. He could not have known that less than a year later, COVID-19 would impact the biomed department and the entire healthcare community in unanticipated ways. Like other members of the biomed team, Paulo was on high alert, ready for a call regarding the need to set up additional patient rooms, each requiring a ventilator, a BiPAP, CPAP machine, and a bedside patient monitoring system. Paulo describes his job as his passion, where everything he does is for our patient. He says, when you work in biomed, you may face a new challenge every day. It can be something simple, like a machine that needs replacing, or something urgent, like a scope suddenly not working during the procedure. We always keep the patient's needs as our top priority. Paulo earned his certificate of biomedical equipment technician certification in the same year he joined our healthcare system. The director of biomedical engineering describes him as the go-to person for dialysis machines and notes that he was recently certified in supporting anesthesia devices. His exceptional work has been noted by many clinical departments, and his colleagues describe him as a great team member who is always ready to provide support when needed. When he is not at the hospital, he's focused on his family and his passion for music. He has played in a band for more than 15 years and is an accomplished guitar player and a singer. He has 2 sons that also share his love for music. So congratulations, Paulo, on an August Employee of the Month. All right, and then I will move on to our health promotion and community outreach events. July, we were busy in the community in many ways. Start there. July 11th, as I've mentioned in the past, we had a booth education booth at the Fremont Summer Concert Series, and really this time focus again on our choking first aid education and mini teach around blood pressure. We did over 65 blood pressure checks. Maria Nunes was in the community talking about stroke education and blood pressure checks. Betty Goodwin, as we heard last month, continues our education in the community around choking and attended the American Business Women's Association. We also had, again, another booth at the Fremont Concert Series, and this time did some education around opioid and distributed Narcan kits and did blood pressures. On the 21st, we were at the Mariachi in the park at the Shirley Sis Grove in Newark and did blood pressures there to over 48. Dr. Harsh Agarwal talked about on July 24th our heart valve disorders in adults, types and treatments, and on that he did that Facebook Live and YouTube and had 53 live views, but 590 non-live views after that. We have on July 25th, we had one of our diabetes program talked about, Nancy Liu talked to this Newark Senior Advisory Committee at the Senior Center and talked about diabetes. Also on July 25th, again, we were at the Fremont Concert Series and talked about, did some mini teaches around diabetes and again, blood pressure, did 79 blood pressures. And also then on July 26th, we did do some on-site education in partnership with Haller's Pharmacy at Acacia Creek and talked about how to guard against opioid overdoses. Again, July 30th, 31st, we did sports physicals at Newark Memorial High School in Irvington. We did 145 and 2,850 were donated back to the Fremont Unified School District and Newark Memorial High School. So thank you to our sports medicine program. Again, we were at the Summer Concert Series. August 3rd, we attended the Cat Williams Memorial Health and Back to School Fair and had 200 community interactions. August 8th, again, we were at the Fremont Concert Series and did fall prevention and blood pressure checks. Moving on to August 10th, we went to the Bay Area. We attended Bay Area Community Health Annual Ohana Health Fair at the Newark Library and did our Stop the Bleed campaign and training around that. We were also August 10th at the Larry O'Carr Show, Ruggieri Senior Center in Union City. Also busy on August 13th, we did the Active Living Daily Practices to Stay Healthy and Prevent Cancer at the Masonic Homes. I do want to say yesterday, if you were over in the Washington West parking lot, We partnered with Dirk Lorenz and Fremont Unified School District and the Fremont Foundation and did the Welcome Teacher Day for elementary school kids who came through, and they were able to get a flower for their teacher to present, and we gave out over 1,300 flowers. So we had a lot of volunteers, and it was wonderful in terms of doing that and partnering with the Fremont Unified School District. Then also today, on August 14th, Dr. Jason Van Tassel talked about sleep apnea. So we've got a few pictures here of all the different events and educational sessions that we did. And you can see we have a number of upcoming outreach events starting through August 17th through September 11th. And again, continuing the education that we're doing in our community and the importance that we're doing. So have a lot of events. Then moving on to our Healthcare Foundation. Just want to remind everybody that the 38th Annual Top Hat Gala is set for Saturday, October 12th, and the funds raised this year for Top Hat will go to support the purchase of our wide-bore MRI for the hospital. So we're very excited that the foundation has agreed to raise funds for this important new MRI that is going to be going into Morris Hyman Critical Care Program. And as we know, Sarah talked about where we stand with our Cancer Center campaign, and we're really aiming towards that $12 million goal with that. So, and of course, the Board of Directors have been busy at the Fremont Concert Series. So that is the report for this evening.
All right, so we'll move on to we have one more action item left, B.
Yes.
Director Nicholson?
Yeah, Mr. President, resolution number 1266. Mr. President, I move that the board approve resolution number 1266, approving best value contractor selection for the Morris Hyman Critical Care Pavilion infill project.
Second.
And we have Ed Fayan is going to just give a short overview of the resolution this evening.
Thank you, Kimberly. Can you hear me okay?
Yes, we can.
Okay, so basically the resolution is about a different selection process for a general contractor for the Morris Hyman Critical Care Pavilion infill project. Instead of doing a simple lowest responsible bidder, it would go to a best value contractor selection, which means that the quality of the contractor and the contractor's experience and the contractor's staff is taken into consideration and figured into their bidding numbers so that a new value is brought up based on their quality. And so the selection is made both on the cost they submit and on the overall quality and abilities of the general contractor. And we thought that this would be the best way to go in terms of a selection for this project because of the complexity of the Morris Hyman infill. You already know it's a base isolated building. We're talking about including ORs, the entire new OR suite, including hybrid ORs, all of imaging, including bringing an MRI into the building, into a base isolated building with all the additional weight of that magnet in a base isolated building, and the complexity tied to also the pharmacy and the sterile processing department. So the thought was that with the complexity of this construction, with the tie-ins of all the systems in a base isolated building, we needed to be extra careful in our selection of a contractor, and it was seen that the best value approach would allow us get the most qualified contractor in this instance. And so that's what the resolution addresses, and that's what we're asking for you to take action on today. I'll take any questions.
Absolutely the way to go.
Yeah. Yeah.
I'll take roll. Director Epen,
Aye.
Director Wallace, Dr. Nicholson,
Aye.
Director Yee,
Aye.
and Director Stewart.
Aye.
Thank you.
Thank you, Ed.
Thank you.
Thank you, Ed.
Thanks, Ed. We're looking for on budget, on time, just like usual.
Yes.
Good night.
Yes, sir.
Under.
Okay. Exactly.
So, we have a closed session.
We do have a closed session.
Okay, then we'll adjourn to a closed session. We'll now go into a closed session. However, before doing so, I want to let the public know that they have a right to know what reportable action, if any, was taken by the board during the closed session. Normally, the board would make that announcement following the closed session. As we do not know how long the closed session will last, we do not want members of the public waiting indefinitely for the board's report. Therefore, we ask that you contact the district clerk tomorrow. She will be happy to respond to any inquiries about the reportable board actions. Our minutes will continue to reflect any reportable actions taken. Thank you.